counts. I mean, we tend to think of healthcare as a binary choice. Either we protect what we've got, or we just end up with American healthcare, right? And again, American healthcare, it's a bad system. All sorts of things wrong with it, including gross inequity and inefficiency. But because of this, Canadians tend to want to protect the status quo here in Canada because they don't they don't want to have to deal with American style healthcare. Um, but again, this isn't simply a binary choice between two alternatives. Anybody, for example, if any of your listeners have lived in a Western European state, they know that some of them actually have reasonably good healthcare systems. And the biggest, I mean, so going back to Canada Health.
Hi, my name's Lester, and welcome to another episode of What's with RWE, the Canadian Healthcare Podcast. Today we have a very special guest with us, Dr. Katherine Fierlbeck. She is the McCulloch Professor of Political Science at Dalhousie University. She's an incredibly accomplished author. I honestly, I don't know how many books you've written, but here are just a few in the recent years. The Boundaries of Medicare, Public Healthcare Beyond the Canada Health Act, Nova Scotia, A Health System Profile, Healthcare in Canada, A Citizen's Guide to Policy and Politics, and most recently, Public Policy Changes in Rethinking Public Health, Comparative Perspectives. Welcome to the podcast, Katherine.
Well, thank you for inviting me.
Yes, thanks a lot for joining us. This is going to be amazing because we are right now, just so everyone knows what date it is, April 24th, 2025, and it's the upcoming elections. And of course, many of the political parties have already actually just very recently put out their healthcare platform. So we're not going to discuss that right in the beginning. However, we'll leave that to a little bit to the end. But maybe, Katherine, maybe we start things off with we brought you on because of obviously Canada has somewhat of a healthcare problem. The core problem, one of the big problems is, of course, long wait times in primary care. So maybe as the expert in this field, you can just let us know why. I know it's a tall order, but why? How did we even get to this point?
Right. Well, I'm afraid it's a fairly long-winded answer. But yeah, it does rather feel like the whole system is collapsing around us, right? Especially for those of us who can actually remember getting care in a timely manner as a matter of course. So, for example, I had a bad bout of bronchitis a number of weeks ago and could barely breathe. So I thought, time to make an appointment with my GP. So I got it my app, because I'm one of the lucky ones who actually has a GP. And the first appointment I could get was in 3 months' time. And my first reaction was, well, by that time, well, this either will have resolved or I simply won't be here any longer, which of course, is pretty much how most people thought about healthcare about a century or two ago. So why are things so bad? Well, it's useful to go back in time a bit and understand how the structures and institutions we have today evolved in the first place. So, interestingly, in the middle of the 20th century, Canada's healthcare system was very similar to that of the US. And then we gradually began to pull away and go down a completely different path. But the story actually starts a little bit before that, during the Second World War, when Ottawa came up with a set of post war reconstruction plans that included federal support for provincial health insurance. Now, Saskatchewan, assuming this federal legislation was imminent, pushed for a provincial plan that would work in conjunction with the federal legislation. And then, when the federal initiative actually fell through, Saskatchewan went, oh, well, let's go ahead with it anyway. And as we know, it became the first province in 1947 to provide public hospital insurance. And because that seemed to work well, the feds actually enacted legislation to support provincial initiatives in hospital insurance across Canada. And the principle of hospital insurance, in turn, was so successful that Saskatchewan then fought for a public provincial system of insurance for physician care outside of hospitals, right? Essentially GP services. And again, Ottawa thought, well, hey, this can work, so let's support this federally as well. And gradually, by about 1972, all the provinces signed on to these two kinds of public health insurance, so hospital and physician. But by the early 1980s, what was happening is that a lot of GPs were charging fees above and beyond the rates set for public insurance. So I can remember as an undergraduate always having to take an extra $10 with me when I went to see my GP, because that's how much I would have to pay directly to my GP above the amount that my doctor would bill the province directly. And that's when the then federal minister of health, Monique Began, said, this just isn't right. And so, again, with the prodding of the NDP, incorporated these two existing pieces of federal legislation, one for hospital insurance, the other for physician services, combined them into what we now call the Canada Health Act in 1984. Now, this background is important to underscore two fairly important points. First, that so much of what happens in healthcare is really, in the end, up to the provinces. And second, that our healthcare system was really set up to deal with 20th century healthcare, and it's not working so well in the 21st century. I think it's probably worth emphasizing that first point. The provinces are the ones who determine what kind of healthcare system we get in each province. They have most of the legal responsibility to provide healthcare. But the problem is that they really can't afford all the healthcare that they provide. So, on average, federal funding accounts for about 22% of provincial health expenditure. Though, again, it varies by province. So, imagine what healthcare in your province would be like if you had 22% less funding, right? Basically, the provinces can tell Ottawa, you're not the boss of me. You're not going to tell me how to run healthcare. They could do that, but then they'd lose their health transfers, and then they'd either have to cut healthcare services a lot, or they'd have to cannibalize other provincial services to support healthcare. Either way, provincial voters would not be particularly happy. And so we're caught in this dance between federal and provincial governments on how healthcare should be funded and delivered. Then, of course, we can get in, if you want to, we can talk about the ways in which healthcare has changed, which again is a bit of a rabbit hole, but quite interesting.
No, that's thank you for that background. It's actually incredibly, I found personally incredibly hard to find these different pieces of disparate information and kind of piece it together to try to understand, like, how did we get here? So that's kind of interesting. This dynamic between you suggested the provinces, not suggested, but this dynamic between the provinces and the federal government, right? And this dance that you talk about. How has it evolved over, like, say since um, the Canadian Health Act at 1984 until today? Like, what has how has that changed? Has that been improved or has it deteriorated? What is your sense?
Well, both in a sense. I mean, healthcare is getting better insofar as we can do a lot more stuff and we've got a lot more treatments. And arguably, the health of the population in certain respects has also improved. One example is that the kind of cancer that Terry Fox had and died of, lo, these many decades ago, is quite treatable now. So things are getting better in that sense. But of course, the more we can do, the more expensive it becomes, and also it's being provided in different ways. So again, the basic problem here is that we have 20th century institutions trying to manage 21st century realities, right? And so things are getting out of sync because of this disconnect. So the population is different. For one thing, we're a lot older now, right? Physicians are different. They have different expectations. They look at life differently. They want to work in a different way. As we all know, they have a lot more forms to fill out compared to decades ago. So physicians it's a different cohort with different challenges. The practice of medicine is quite different. And, again, somewhat ironically, it's actually almost a lot more labor intensive now with all the data input required. And even medicines themselves are different, right? We can treat a lot more conditions through drugs rather than wait and see, or rather than, very invasive surgeries. But so because things are so different, because of this disjuncture, we see the growth of private healthcare due to a lot of these gaps and these loopholes that are emerging. And again, here's where we're going to have to get into the weeds a bit. And it's interesting that most people simply don't understand how the Canada Health Act works. In fact, I was reading a CBC article a couple of days ago that said things like the Canada Health Act prohibits charging for an essential medical service like primary care that's publicly available. But in fact, essential medical services can be provided privately if they're done by, say, non-participating physicians. It also said that Quebec physicians can choose between the public and private systems, but it's not the case in most other provinces. But in fact, that is the case in all provinces except Ontario. And in fact, there's a tendency, an interesting tendency, to see Ontario as a standard for what is the case. But in fact, it's actually quite the outlier when it comes to private health insurance. So, basically, if journalists can't get it right, it's hardly surprising that the rest of us are fairly confused. And, to be fair to journalists, the landscape is incredibly complex, and my head still hurts when I try to unravel some of these things. So, to explain how things really are, which again is a lot more complicated. Well, let's go back again in history, but let's go back to Saskatchewan in the early 1960s. So when Saskatchewan tried to enact Medicare, so Medicare, public insurance for physician services, right? And when Saskatchewan tried to enact this in around 1962, the doctors immediately went on strike for like 3 weeks. Hugely acrimonious affair. And it's kind of interesting why that was the case. So in Saskatchewan, as was the case in many provinces, who were the doctors? With a lot of the doctors, about in Saskatchewan, I think maybe a third of the doctors at the time were British. And why were so many doctors British? It's because they were leaving a system that had become essentially nationalized, right? So the National Health Service was set up in about 1947. And a lot of doctors, on principle, thought they'd just become slaves to the state, didn't want it, so they thought, well, let's go to a country where we're free to practice how we want. A lot of them ended up in provinces like Saskatchewan, and then all of a sudden they're facing exactly the same thing. So of course they're absolutely furious, and it was a real powder keg. So that was the context, and so they went on strike, dragged on for 3 weeks or so. And when Saskatchewan decided, well, we have to calm the doctors down, how are we going to get them to agree to Medicare? What they said was that those physicians who wanted to practice Medicare outside of the public system could do so, right? That's fine. You can, if that's what you really want, then, fill your boots. And essentially, this provision was duplicated across most provinces as well. I think Quebec also had a doctor strike around 1970, and again, doctors were offered more or less the same kind of deal. Okay, if you want to work outside the system, here you go. You know, some provinces, like I think New Brunswick, even protect this right, the right for doctors to work outside of the public system. They protect this right in legislation. So essentially, we have two healthcare systems working more or less in tandem, right? So first, there's the single tier system of healthcare that existed more or less for the past 4 decades. When we think of Canadian healthcare, we think single tier healthcare. We don't want that, that stinking two-tier healthcare system. But in fact, there's always been this, if you wish, this shadow two-tier system, insofar as legally, physicians have always been able to provide care privately, excepting Ontario since 2004 when they passed the Protection of Medicare Act, I think. So this has always been the case. We've always had this other, so if, as I've said, this shadow two-tier system. So the question then becomes, well, okay, so why are we only now seeing this in practice? And the problem, again, is that the Canada Health Act is firmly grounded in 20th century healthcare models, which are, again, increasingly obsolescent. And most specifically, the Canada Health Act assumed that all healthcare would continue to be provided by doctors and in hospitals. And the problem is this isn't the case any longer, right? So, for example, you've got nurse practitioners, you've got pharmacists, paramedics, physiotherapists, prescribing nurses, and so on, all of whom have much expanded scopes of practice. And of course, it varies from province to province. So I know in Nova Scotia, where I live, paramedics can sedate patients and essentially, fix broken bones. Physiotherapists can ask for diagnostic tests. Prescribing nurses obviously can prescribe. Paramedics can diagnose, so on and so forth. So we've got these expanded scopes of practice, which are rolling out differently across all the provinces, and started before COVID, but we're really seeing this a lot more post-COVID, and governments like it because, as we know, doctors can be a bit pricey, and other healthcare professionals can do a lot of the same things a little bit cheaper. And in fact, if you actually look at nurse practitioners' scopes of practice, again, they vary across provinces, but in a number of provinces, including my own, they can pretty much do everything, all the regular stuff that GPs can do, but they can do it a lot cheaper, right? So, of course, provincial governments like that. But the problem here is the way that all of this intersects with the Canada Health Act. So, what the Canada Health Act does is to tell provinces, you decide which services you want to insure publicly. But once you've done so, these services have to be available to everyone in your province on equal terms and conditions, right? Comprehensiveness, universality. But here's the thing. This is what a lot of people don't realize. The Canada Health Act defines insured services as only those that are provided by doctors or in hospitals, right? So according to the Canada Health Act, any services, even if they duplicate those done by physicians, are not considered insured services. I appreciate some of your listeners won't see my rabbit ears here, are not considered insured services if done by, say, a nurse practitioner rather than a doctor, right? So stitching up a cut, well, if a GP does it, then it must be publicly insured. If a nurse practitioner does it, then it doesn't have to be covered publicly, and so it can be provided privately, which is why we increasingly find private clinics staffed by nurse practitioners, where essentially nurse practitioners can, somewhat ironically, charge higher rates than GPs for the same service. And similarly, we have these non-participating physicians. Now, again, these were the physicians who told the government of Saskatchewan, we don't want part of your friggin' state run healthcare system. We want to practice. So we've got these non-participating physicians, not in all provinces, but in most provinces. Some provinces have opted out physicians. It gets a bit, again, to get weedy here. But we have physicians who are not part the who are not enrolled in the public system. And these physicians can, in fact, provide medically necessary health care. Again, because, let's bring up the rabbit ears here, insured services in many provinces are defined as services provided by enrolled physicians, let's say enrolled in the public insurance system. And so if physicians are not enrolled, they are not providing insured services. And so these services can be provided privately, even if they're medically necessary, because they're not insured services. And again, remember that the Canada Health Act doesn't say that all medically necessary services have to be provided publicly, just insured services.
Got it.
Now,
Got it. Wow,
again, there's
that's
another angle
amazing.
here.
No, but
So
that's amazing.
I know, isn't it?
Appreciate the
And
deep
it's
dive.
incredibly complex. And you have to keep in mind that the Canada Health Act is only like 3 pages long. Well, 6 pages if you have both languages. But it's not just what the Canada Health Act says. It's also how it dovetails with all the different pieces of provincial legislation. So again, you might well ask the question, well, okay, I understand that, but why is this just why wasn't this an issue in the 70s? And the reason that this wasn't an issue for several decades is because so we tend to think that, oh, the only thing we can do to stop private healthcare is to pass legislation banning it. But that's not what we did. And Canada has been quite clever insofar as even in Ontario, where they have effectively banned public health care, but they haven't said we ban public health care. They've just defined it in such a way as to make it impossible for doctors to provide private land. I can run through that later point if you want. But so the reason that we didn't have this burgeoning private healthcare for a long time is because the constraints on private practice in most provinces rested in the fact that it was made economically unattractive to do so, right? So you can put fee caps on these. So you can say, okay, you're a GP, you can provide care privately, but you can only charge the same amount that you can only charge up to the public tariff, like what doctors who were enrolled would get. So if it's just a consultation, $35 is a public tariff, then you can only charge up to $35. Well, if that's the case, why would doctors work in the private sector if they were paid the same rates as those in the public sector? And then, of course, to the extent that again, those of us who are old enough to remember actually being able to get a doctor's appointment the next day, the same day, if you can get a GP appointment easily the next day, why on earth would patients pay more for services if you can easily get them free at point of care, right? In other words, again, private practice wasn't disallowed per se, except in Ontario after 2004. It's just that there were a lot of economic disincentives placed on it. But, and here's the problem. Of course, once primary healthcare becomes a scarce resource, which it was beginning to do before COVID, and certainly is the case now, and even again, if you have access, if you are attached to a GP, God only knows how long you have to wait before you can actually access a GP. So, primary healthcare becomes a scarce resource, and because of that, unsurprisingly, market principles, then people become more willing to pay for it. And as more and more people become willing to pay for these services, there's a larger pool of clients for doctors, right? And so the private model actually, which has always been legal, becomes a lot more viable. And we can certainly see this in Quebec with over 800 doctors practicing privately right now.
So, okay, that's very interesting because I'm hearing a couple things and I'm pulling a couple of threads. But recently we had a conversation with Dr. Josh Reimer, who's the president of the Canadian Medical Association, and we just asked her the question, just quite frankly, like how did we get here in terms of doctor shortages and also long wait times, and she put forth two specific key things she thought contribute to it. One of which you've talked about, which is demographics. Just the population's getting older, and when you're getting older, you tend to have to use more healthcare.
Mm-hmm.
And then the other component is I guess in the 1990s there was a effort to, I guess, reduce the overall budget and like balance the budget. And
Yeah.
because of that, there was some structural things that were done that basically limited the amount of almost like training of medical students. So she postulated those two things as the key contributors to, the longer delays now that we have. But you're actually putting in another structural problem, which is actually the Canada Health Act that hasn't evolved since the 1980s, and that actually creates disincentives for some potential solutions, like certain for instance, a certain type of private healthcare to kind of come in and meet the needs that is somewhat disincentivized, right? Am I thinking about that correctly, or is that completely just too naive, Catherine? Would you say that there's another layer to that?
No, the problem is that the Canada Health Act just isn't a good fit for what's going on. And it depends what you think the solution is. So if you think everything should be kept in the public sphere, then again, the Canada Health Act doesn't address ways in which healthcare is increasingly being provided. And if you believe in more private healthcare, you think that the Canada Health Act is still, a drag on some of the possibilities that we have. So interestingly, in January of this year, Ottawa, the Health Canada Minister of Health federally released what's called an interpretation letter, and these are interesting documents. We've had four so far. This is the fourth one. No other piece of federal legislation that I know of has something called an interpretation letter. And yet we have this one federal statute, the Canada Health Act, which now has four, which is itself, I think, a really interesting phenomenon. And what these interpretation letters originally were set out to do was to clarify, because, when the Canada Health Act was set up, like I said, it was a very small document, very short. So an interpretation letter was issued by the federal health minister a year after the Canada Health Act came into being, saying, okay, here's exactly what we mean by this, that, and the other. So for example, under the terms of the Canada Health Act, can provinces still levy premiums? Again, they were interpretation letters. And increasingly, these interpretation letters have attempted to expand the scope of the Canada Health Act. And it'd be interesting to talk to some lawyers here, because the question becomes, are these so-called Bunny, you're saying these interpretation letters, how much legal force do they actually have? Now, technically, an interpretation letter is just that. It can't change the nature. It can't change it can't change the act itself. So they don't have any binding force. And increasingly, so in 2018, the federal government issued a interpretation letter imposing what they call the Diagnostic Services Act, which came into force 2021. And this essentially said that provinces should publicly cover medically necessary diagnostic services. Some provinces already do that. I think Ontario does it. Just say, yeah, I'm going to do that. A lot of other provinces don't do that. And again, my province is one of them, where if I had to get an MRI done, I could wait 6 months or more, or I could get it done next week. And I could walk to the private clinic and I could plonk down my $900 and I could walk away with whatever scan I needed. And the federal government says, no, this is against the spirit of the Canada Health Act. And provinces are still pushing back. So there are these scofflaw provinces, if you will, that just went for various reasons. And so in 2025 January, Ottawa brought forth this fourth interpretation letter, and they introduced the Canada Health Act services policy to deal with this disjuncture that I just mentioned about other non-physician healthcare providers increasingly providing medically necessary care. So this new interpretation letter essentially is saying that the spirit of the Canada Health Act is that all medically necessary services should be publicly insured. And this is what most people think the Canada Health Act says, except, as I mentioned, this is not what the Canada Health Act actually says. And the reason it doesn't say all medically necessary services, but rather insured services, was to give the provinces more leeway in determining what kinds of services they wanted to insure. But the provinces, I think, with this last letter, the provinces can rightfully respond that that might be the spirit of the Canada Health Act. But unfortunately, the letter of the law is that only medically necessary services provided by doctors or in hospitals have to be covered publicly to meet the terms of the Canada Health Act, because that's what the Act says, right? So you have this really interesting situation in which the Canada Health Act defines insured services as X. And this new interpretation letter says, actually, we want to change the definition of insured services. Well, legally, can you do this, right? It's sort of like saying, well, I've got this contract with a gardening company, a landscaping company to mow my lawn during the summer every week. And then about halfway through the summer, I say, well, by mow the lawn, I actually mean clip my hedge as well, right? So it's an interesting, and again, it's a very political, interestingly political standoff, if you will. It'll be interesting to say. It'd be interesting to see what the provinces decide that they want to do about this.
Actually, this is okay. I know that people generally say that there's no stupid question, but I am actually going to ask a stupid question just to show how naive I am in this case. Is the Canada Health, is that a law? Like what do you, and then do the provinces then have like additional laws that have to then dovetail with the Canada Health Act? Like what do you even call, is it a law? I guess I'm not even sure
Well,
what it is.
actually, it's a really good question. It's a very foundational question. So the Canada Health Act is a federal statute, which means that the federal government has passed this act in Parliament. Um, but of course, as you know, the federal Parliament cannot pass an act that transgresses provincial jurisdiction, and for various historical reasons, um, the Constitution has been interpreted as saying that essentially the provinces have jurisdiction over healthcare. So the federal government cannot, um, according to the Constitution, interfere with areas of provincial jurisdiction. But, and I mean, you can talk to a constitutional scholar and they can fill your ear, and this is kind of interesting as well. But just because they can't legislate in the area of healthcare, they can give money to the provinces on a purely voluntary basis. So it becomes more like a contract. So the first thing to remember is that because the Canada Health Act is a federal statute, it is not binding on the provinces. Okay, that's ultra vires. That's a no-no. But the act can and does allow the federal government to send money to the provinces. And what the Canada Health Act essentially does is outline the terms of the contract, in terms of the agreement whereby the federal government agrees to fund the provinces. And of course, the provinces, as I said, rely on this federal funding. And so you can think of it, so it's binding on the federal government, which is important in another aspect we can talk about later. But it's the Canada Health Act is not binding in a legal sense on the provinces, but it's a quid pro quo. It's a contract, right? You want this money? Okay, here are the hoops that you have to jump through. You don't want to jump through these hoops? Fine. There's nothing we can do. But of course, is it possible that the provinces can actually uh, provide healthcare without this money? Well, it's probably not. Again, it would be a real hardship. They can legally, but politically they can't. They're sort of locked into this politically, right? So the Canada Health Act is, again, merely binding on the feds. And this does raise another related, interesting legal issue, which is that because this act is binding on the federal government can't ignore it, right? And again, we're sort of, brushing away the weeds here as we go down this route. But what exactly is it that the federal government has to do? Well, there's two things here. And if if you can't sleep and you you want to bore yourself, read the Canada Health Act. Actually, it's a little bit more interesting than it might actually keep you awake. And so there are these five provisions of the five provisions of the Canada Health Act, accessibility, comprehensiveness, universality, portability, public administration. These are set out. You want the money? Okay, the Canada Health Act said to the provinces, you want our money? Then you have to set up legislation enshrining these five principles, which are fairly amorphous principles, but fine. And that's why provinces have slightly different pieces of legislation. They, in their own ways, meet these five provisions. Okay. But here's the thing. Here's what becomes kind of interesting. The legislation, the Canada Health Act, says that the federal, if any of these five provisions are not being supported by the provinces, Ottawa has the discretion to pull its funding, right? It doesn't mandate it. It doesn't say you must. It just says you've got the choice. So Ottawa, if you want to bring out the big guns and pull the funding, you can do that. The interesting thing is that historically it's never done so. It's never done so. It does have the legal ability, but it's never done so. However, those are sections 8 to 12 of the Canada Health Act. And if this gets too boring, you can just cut this out of the podcast before you air it. So there are two other sections of the Canada Health Act, sections 18 and 19, which are often called the EBUC provision. And EBUC stands for extra billing and user charges. And here's where things get a bit more interesting, because section 18 says thou shalt not extra bill. So if a province permits a physician to extra bill, like the situation I was familiar with when I was an undergraduate, the physician bills Ottawa and then says, oh, that'll be another $10. So if a province is found to have allowed this, then the federal government will claw this money back. For every $10 that Dr. Smith charges, Ottawa will claw that money back. So that's extra billing. User charges is if I go to a GP, often called things like tray fees. If I go to a GP and the GP says, well, I could suture your cut, but oh gosh, these things are expensive, so I'm going to charge you for the needle. I'm going to charge you for the cat gut. I'm going to charge you for the Band-Aid, right? That's extra billing. And so basically what section 20 or 21 of the Canada Health Act says is that Ottawa absolutely must penalize a province if the province is found to be doing this. No ifs, ands, or buts. So Ottawa, all the penalties that Ottawa has ever levied on the provinces have been for transgressions of Section 18 and 19. But the thing is that for things like the Diagnostic Service Policy, which came in 2018, and the current Canada Health Act Services Policy, Ottawa has articulated or has essentially threatened that it will penalize the provinces by utilizing sections 18 and 19. But again, using nurse practitioners providing insured services, that's not extra billing. I don't know how you can call that extra billing, and it's not user charges either. So why the hell is Ottawa using sections 18 and 19, which are mandatory, rather than something like section 19, which says, essentially that people should have access to healthcare because of need rather than ability to pay? Why not levy a penalty under section 9, under section 9? Well, so the issue here is that Ottawa refuses to use its discretionary capacity, and is really weaponizing the Canada Health Act by using these two small provisions, which are mandatory, even though, in my estimation, they don't really seem to fit well. So it's an interesting phenomenon at the moment. And again, the more you're depending upon these two sections of extra billing and user charge to do all the work that you want the Canada Health Act to do, the less legally coherent it becomes. It's a long-winded
God.
answer. Feel free to
No,
edit
no,
it out.
no. This is amazing. I love this type of conversations, just because it's so much of the nitty gritty is it actually contributes so heavily
Mm.
to how things are today. It's great to understand that. I know now this is actually a great framework to think about. Actually, I never thought about the Canadian Health Act, as it's not. It's almost like you suggested, it's a contract between the feds and the provinces. Like, not that you have to do this, but if you don't do these things, then you don't get this extra money, right? Like, here's the carrot, and the stick is we take the money, take the
Exactly.
money away, right? Now, thinking about potential solutions, you talked about two possible. Well, I guess there's many possibilities, but the two kind of extremes. One would be private, and one would be everything public, right? Like, I'm sure there's intermediates in between that as well. Like, how would the Canada Health Act need to evolve in order to allow for, let's say, both the public and the private solution to, let's say, from a public would be, let's say, nurse practitioners being more prevalent, right? Like, for as example, could you lay out how the Canada Health Act would need to change, and actually, how would you even change it?
Yeah, but you can change the Canada Health Act, but there's a lot of other things. There's a lot of other possibilities that we could do. I think that our evaluation of our own healthcare system is pretty distorted by our proximity to the US, which really is a poor system on so many counts. I mean, we tend to think of healthcare as a binary choice. Either we protect what we've got, or we just end up with American healthcare, right? And again, American healthcare, it's a bad system. All sorts of things wrong with it, including gross inequity and inefficiency. But because of this, Canadians tend to want to protect the status quo here in Canada because they don't they don't want to have to deal with American style healthcare. Um, but again, this isn't simply a binary choice between two alternatives. Anybody, for example, if any of your listeners have lived in a Western European state, they know that some of them actually have reasonably good healthcare systems. And the biggest, I mean, so going back to the Canada Health Act, the Canada Health Act could say, and what it's trying to do is to say, okay, basically, provinces, you have to expand the kinds of services so that all the services provided by all these other non-physician healthcare providers have to be covered. And the provinces are going, okay, right. Who exactly is going to pay for this? So the feds are upping the ante in terms of costs. And that's really where, the rubber hits the road is, it's fine to say, oh, you should do this, you should do that. But, if the provinces say, well, if you're not going to help us pay for it, then forget that. And another important thing that Canadians should know is, is to think about what's covered. So probably another structural issue, the biggest weakness of the Canadian system is that it's narrow and deep, right? Which means that we only insure two aspects of healthcare, right? We insure hospitals, hospital services, and we insure physician care. And people pretty much have to pony up for anything else. So, for example, if your doctor says, well, there's a drug that will cure you and you don't even have to go to the hospital, well, that's great news. But only if you have private insurance, because otherwise you're paying for your treatment out of pocket because it's not being provided by a GP. It's not being provided in a hospital, right? And increasingly, as we know, the kinds of treatments that people are using, things like pharmaceuticals or all the mental health care services, are usually not covered unless, again, they're provided in a hospital or you have a particularly generous provincial healthcare system that says seniors can get insured for blah 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 or whatever. So while we think of our system here in Canada as highly equitable, in fact, it scores consistently quite low on international indicators of equity because, largely because so many people have to pay for their own care unless it's provided by physicians or hospitals, right? So there are huge inequities in the Canadian healthcare system that we don't like to think about. So, we could, for example, contrast this with a system like France, which, rather than being narrow and deep, is broad and shallow. And this means that the French system covers a lot more things than the Canadian system, right? And not only drugs and counseling, but also things like dental and optics and physiotherapy. And in fact, France has, I think, one of the lowest rates of out-of-pocket payment in Europe, and much lower rate than Canada's. But at the same time, France rarely pays the full cost of everything. So in generally social insurance, which essentially is public insurance, so essentially the public insurance pays 60 to 80% of costs, right? So if you're in a hospital, you pay the remainder. You might pay 30% of your care. You go to a GP, you pay 30% of your care. So almost all people in France have private insurance to cover the remaining, 20 or 40%. So the state will cover public insurance, social insurance. It'll cover 2/3, say, but the remaining 20 to 40%, people have to cover it themselves. So people will take out private insurance. Now, you might well say, well, that's regressive, right? Because poor people have to spend a greater proportion of their income on private insurance. And you'd be absolutely right. So what France does is to ensure that the less well-off not only have the public insurance that everybody has, right, but that their complementary private insurance, what's used to pay the remaining 20 to 40%, is also essentially paid for by the state. So there's like a parallel system to this private complementary health insurance that is actually state health insurance that mimics private insurance, but it's for the less well off, right? And it's kind of neat that the French state funds this faux private insurance for poor people by taxing the private insurance companies, right? As well as through sin taxes like liquor and tobacco and whatnot. So it's got a lot of mechanisms to ensure that while there is a private presence, what you do is protect the less well off, right? And what else? The French state also ensures that the private insurance component isn't disadvantaged to poor and sicker people by ensuring a fairly strict regulatory framework on this kind of insurance. So Here in Canada, we think public, private, public good, private bad, public. But essentially, what most European states understand is that that's not the relevant um, way of thinking about healthcare, because you can have private healthcare that that faces so many regulatory requirements that essentially operates the same as public healthcare. So it could be, again, for example, more progressive rather than regressive. And the principle behind the French system is that healthcare, should be available to people on the basis of need rather than the ability to pay. That's the principle for French health. Does it sound familiar, right? So it's very similar in that. So its objectives are very similar to Canadian healthcare, and while France does allow private players, they rigorously incent them to follow what France calls solidaristic principles, using tax and other incentives. So it's a completely different system than the one we're used to, but at the moment it's actually doing a better job than our system, notwithstanding its own issues and problems. Of course, it has them. It's very complex. It's pretty expensive, but you can't get everything, because if there were a magic bullet, we'd all be doing it. And now that's, of course, it's not to say that we should drop everything and emulate France immediately, but rather that there's all sorts of ways of doing things differently that don't involve just becoming more like the US. So we should be open to be at least thinking about doing things differently, because simply doing things differently doesn't automatically give us American style healthcare. And in fact, doing nothing opens up all these gaps and loopholes, which does basic private healthcare. So there you go.
No, that's a very, very nuanced kind of take on it. So I appreciate that because, of course, you've studied health systems across the world. So that's good. It's kind of a good framework. That's not necessarily private or public, but it's like what is the outcome that you would like to achieve, and then both different aspects of private and public have their issues or their pros and cons, and then it's how you blend it together. So that's very interesting. The one thing I kind of, this is a little bit of a somewhat of a pothead question, but I'm going to ask it anyways. I've heard this in other podcasts that we've done with other folks in when we talked about value-based care and so forth, around how our healthcare system is in some ways, it's incorrectly named as really a sick care system. It's really, you get sick, then you go and get treated, right? And that true healthcare would be almost like do a lot of preventative stuff. And a lot of the things you read about how to improve your health generally kind of falls into a couple of things, right? It falls into like eat better,
Mhm.
exercise, get more sleep. Somewhere within that framework, right? Is there a way, or have you seen other countries almost try to, I don't even know what's the best way to ask this, like to incentivize those things in their quote unquote healthcare system? Or is that just like everyone's healthcare system? It's like that's too difficult to manage, that it's really managing the sickness part that's easier, so everyone does it that way? Or is there certain countries that have done like this, almost like look at that from the preventative side?
Oh, absolutely. And the problem is we know that things like good housing and education, green spaces, I mean, we know that these kinds of things uh, minimize the kinds of illnesses and diseases we have out there. The more that people eat better and exercise, if they live in reasonably good accommodation, they will have better health. We know that, and we know that this will keep them out of hospitals. What we don't know is how to sell this to the public such that they would accept this. So, essentially, these are called the non-medical determinants of health, or the social determinants of health. And we know that there's a link, but the problem is, or the question is, how much will we as a society agree to pay for these things, right? And the problem is that the people who are taxed the most already enjoy these things, so they um, are not as inclined to increase taxes to pay for the things that we know generally will work. And that's, I mean, that's the kind of political dynamic you find in every country. Some countries, the Northern European ones, so for example, the Netherlands has a really good healthcare system and is quite thoughtful about these other non-medical determinants of health, but they also are willing to pay for them. And Canadians are a lot more like Americans, and they, insofar as they don't want the state to get involved in these kinds of things. So again, we know that these things work, and that if we had really good housing, then the health of the population would probably be better. But how we get to that point, again, is a hugely political issue, and we just don't know how to get there. And also remember, it's also that there's so many, where there are winners, there's also losers. So anything as seemingly anodyne as limiting the advertising of junk food to children. We tried to do that federally, and it always failed. Why? Because you had interest pushing back. So, for example, um, you have companies that shall go nameless that support sports for kids, like little like soccer leagues, and if the when the advertising was suggested, some of these companies went, well, if you're not going to allow us to sponsor uh, junior soccer, then if you're not going to allow us to advertise, and advertising has their emblem on the soccer jerseys, if you're not going to allow us to do that, then I guess we can't sponsor soccer. Well, of course, all the bourgeois parents who'd love to have their kids in these leagues are going, well, we can't afford hundreds of dollars to put our kids in these soccer leagues. So we want these companies supporting soccer leagues. So we don't support your. So there are all these commercial. These are called the commercial determinants of health. So there are all these commercial interests which push back in such a way that the public recognizes that, again, it may be advantageous immediately for them to tolerate their presence, even though in the long run, we know that there's a link there. So these are hugely politically intractable problems, and some countries have better ways of dealing with them. Some populations are much more receptive to them, but in Canada, it's a bit of a hard slog, actually.
Interesting, interesting. So in some ways, it's like cultural. It
Yeah.
plays a very very strong piece part in that. And apologies, I should have like asked this right in the beginning, but I didn't. And I know we're right up against time, so I don't want to take up too much of your time. I found this conversation myself like incredibly fascinating. I love going to the weeds, especially in things that play such an important part in people's lives like healthcare, but like the policy aspects and the legal aspects of things. So this is amazing. But how did you get involved into studying this? Because I'm sure you could have done a whole host of other things. But I'm glad you're doing this because I'm glad someone's doing this because this is so important. But like,
Yeah,
how was your career geared towards
it's
this?
kind of funny. It's a hard area to get into because it's so technical. I mean, it requires a lot of things. You sort of have to understand how healthcare works. So you get a lot of healthcare researchers who understand the healthcare system, but they're not trained in policy and politics. So for somebody with a political science background to get involved in healthcare, you really have to do a lot of digging and a lot of basic work understanding the system before you can actually see what's happening and why. And um, the problem is a lot of researchers, I mean, we've got so many really good health services research, but because it's such a huge animal, a lot of the research looks at, small issues like, what are good primary team models? What's a good funding model for, which are really important issues, but it doesn't give you a sense of the larger landscape. And you're making me sort of own to my age here, but again, when I was a graduate student in Britain, I broke my arm quite severely and ended up in a hospital. And I was put in a room, and they sort of forgot about me for a few days, and which outraged my this political sensibilities of my friends. And what was happening is that the hospital, the whole NHS was in a state of major health reform through the Griffiths reform. So these are the first Thatcherite reforms, which brought in the market model, the that the first major. Of course, Britain went through a lot of major healthcare reforms, and I thought, being caught up in the middle of it, I thought that was really quite interesting. But again, it really does take a lot of footwork to be able to see what's going on. But with the advantage of age, you really have a longer horizon, so you can look back and you can see why things happen, and what was going on, and what the trends are and how things are changing. So it does become easier over time.
Is it a, sort of a maze? I guess do you have a mind that loves to put together puzzles, or do
It
you
is.
want policies to change to? Sorry, go ahead.
No, it is. Some kids have a very physical sense of taking things apart. You have stories about kids taking apart toasters and whatnot and putting them back together, and I think some people enjoy doing that to abstract systems as well. How does the system work? And of course, with healthcare, it's gears within gears within gears. And the Canadian healthcare is really one of it's amazing that we're actually doing as well as we are, because not only do we have a lot of the same problems that every other healthcare system has, primary healthcare, shortage of healthcare workers and whatnot, but we have to do this and negotiate, federal provincial dynamics on top of everything else, right? Which adds another level of complexity to an already, very wickedly complex system. So it is a bit of a Rubik's Cube, if you will. Or if to
Got
use a
it.
Star Trek reference, three-dimensional chess.
Not four-dimensional yet, right?
Yeah,
But
exactly.
I know we're way over time now already. That I promised you that I'll let you off the hour, so apologies on not doing that. But this has been a fantastic conversation. Very, very. I enjoyed it a lot, and I know the listeners will kind of help them understand all this background that's so important for how the healthcare system is currently shaped. If people want to kind of follow you and see what you're up to, I'm trying to find. Do you use any social media accounts, or is your email the best way, or like
Yeah,
what's the best way
I
for people to
mean,
look
I'm
at?
out there. My email is easy to find. With a name like mine, it's hard to hide.
Mhm.
And I'll post infrequently when I'm giving a talk or whatnot. Then I will post infrequently on Blue Sky. I'm still on Twitter. But otherwise, that's my social media presence.
Blue Sky. So if people want to follow you, Blue Sky is the best place to maybe take a look at your work.
Yep, Blue Sky or Twitter.
Great, and I'll put down in the show notes a link to that so that people know where to find you from at least on Blue Sky. But this has been a fantastic conversation. I very much appreciate it, especially with the backdrop of the federal elections coming up. And after that, maybe I will it'll be great to have you back on to see what you think once something gets done, right? Right now, a lot of perhaps pleasantries have been exchanged, right? But until a couple of things, maybe a couple of dominoes fall over, then I'd love to have you back on the podcast, Katherine.
My pleasure. It's been a fun chat. Oh, and Lester, happy birthday.
Oh, appreciate that. Thank you very much. Appreciate that very, very much. Thank you, everyone, for listening to the podcast. If you have any comments, please like, share below. And then also, if you like this type of content, please follow our podcast channel on What's with RW on YouTube. Thank you very much, everyone. Have a great day. Thanks a lot again, Katherine, for the birthday wishes and, of course, the lovely conversation.